Welcome to the PowerPoint presentation of the traumatic effects of school shootings. My name is Esmeralda Teresa Hernandez Polanco. I am a student with Northcentral University and studying in my doctoral program in psychology with an emphasis in disaster relief. This is for course Psych 8312, Concepts of Trauma and Resiliency, and today is June 25th, 2022. I'm going to be showing you the effects of school shootings, a 5-minute video on some of the most devastating mass shootings that happened in a school setting. Now, the definition for a mass shooting, it occurs when 4 or more people are shot in one location. School shootings began approximately 50 years ago. The 4 top deadliest shootings in the past 21 years that resulted in 13 to 33 deaths were Columbine High School in Littleton, Colorado in 1999, Virginia Tech in Blacksburg, Virginia in 2007, Sandy Hook Elementary School in Newton, Connecticut in 2012, and Marjorie Stoneman Douglas High School in Parkland, Florida in 2018. 60% of all school shootings occurred in high school settings. Usually, mass shootings are, and I quote, symbolic and reflect an anger directed at
Jesse
sections of
Lewis was
society.
6 years old.
Cimolai,
He attended Sandy
2021,
Hook
page 2.
Elementary School.
Now
My
I'm going to show
beautiful,
you this small
bubbly,
video.
and bright, forever
It's a
14-year-old
5-minute
daughter,
video, but
Gina
it
Rose,
shows you
was murdered
real life people
in
who
her
have
school
experienced mass
in
shootings.
Parkland, Florida.
Chris Hickson, he was 49 years old, just a few days from his 50th birthday. He was the security monitor and athletic director at Marjorie Stoneman Douglas High School.
Lost my daughter, Rachel Joy Scott, in the Columbine tragedy.
Eyewitnesses say the 2 gunmen wearing black trench coats and black masks came in shooting and began working their way through the school.
If you wind your way back through all the mass shootings that have taken place over the last 23 years, you would end up with my daughter because she was the first one to be killed at Columbine that day. Well, the hardest thing was just not having her. I mean, I would wake up many mornings and for just a few seconds would forget that she had been killed and expect her to be there.
911, what is your emergency?
Yes, I just got a call from Douglas High School. A female on the line advised that they believe there's a shooter at the school.
Every day we miss her just being here. We miss her being part of our family. We miss seeing her smile and hearing her talk to us. It's just so painful every day.
Chris and I were together for 32 years. There's not a single decision I ever made in my adult life that didn't center around Chris. To be alone and do this solo, it's very hard.
Here in Newtown, Connecticut, the site today of a mass shooting, and this time gunfire aimed at elementary school children.
27 dead in the shooting incident.
Even when one of my coworkers came up and told me that there was a shooting at my son's school, I really wasn't even worried. Got to the school, most of the parents had already been reunited and left. A group of us obviously waiting for hours. And of course, it slowly became apparent to me that Jesse was murdered. But I mean, I was in shock. I think I still am in shock.
We begin in Uvalde, Texas. A tight-knit community wept and hugged, mourning the 21 lives lost in Tuesday's mass shooting.
There was the news about Robb Elementary in Uvalde, Texas, and it was, as it is every time, like a punch to the gut. I would say to them, you are not alone. We love you. We hold your children in our hearts, and we always will.
If their experience is anything like ours, the goal right now is breathing. The goal is to get through the next hour. Your child was just taken from you at some place where they should have been safe.
We know what it's like to not know whether our daughter was dead or alive for over 24 hours because we didn't get official word until the next day. My heart is broken for you. I really know what you feel. I know what you're going through.
And I guess he just shot her. How you look at this girl and shoot her?
All of us definitely have PTSD. I continued to work as a teacher after February 14th. I am nervous every time I walk into a school. I'm always surveying what's the best way, where would I go if something happened? This is not a short journey. Anyone that tells you that it gets better with time is lying.
It's really tough. It's been 10 years, and it's like it's yesterday.
All of us need to demand a Congress brave enough to stand up to the gun lobby's lies.
What President Obama had said when he landed at Sandy Hook, it was gun control. We're going to do gun control. And I thought to myself, well, that hasn't worked. My son is dead. I'm really kind of sick and tired of hearing gun control. I mean, it's been 10 years since Sandy Hook and 20 years since Columbine. If we prioritized the safety and well-being of our children, they would be safe.
We want to get people the help they need before they resort to violence. Right now, we have nearly 20 states in the District of Columbia with red flag laws. Again, they're one of the most proactive tools that we could use. So if Congress could come together and pass some form of red flag law, that would help all of us be safer.
Republican lawmakers are now coalescing around safety protection orders called red flag laws that would allow courts to take guns away from potentially dangerous people.
In the state of Florida, very quickly after our shooting, they did pass red flag laws. They did increase the age from 18 to 21. They banned bump stocks. We're not done. There's a lot of things that still need to happen.
Getting out of this numbing kind of hopelessness, despair that we seem to be in right now, anxiety and fear, having the courage to step outside of that and make sure that we're doing what's in the best interest for our kids.
There needs to be more emphasis on softening the heart, as much at least as on hardening the target. We don't want to turn our schools into prisons. I wish that we could put as a priority the safety of our children over our politics.
I know that that could be a very emotional and heavy video to watch. So if this video triggers anybody, please reach out to school resources. If you have your own therapist, support groups. I know it could be difficult and triggering if you have been the victim or are a survivor of any type of violent shooting or violent trauma. So again, I want to put that disclaimer out there that if you do need to debrief or to speak to someone, I can offer you resources, and you can always speak to someone at your school, to a family member, a friend, or if you are in your current mental health treatment. Is impacted are adolescents, children, adults, communities, families, and individuals. Both the victims and survivors feel out of control, anxious, and helpless. Survivors and family members may commit suicide. Survivors live with survivor guilt. This is the #1 factor in attempted suicides. This guilt that they live with are thoughts of what they could have done to prevent the attack. Many experience social phobia, panic attacks, and major depressive disorder. In a community, when you see a school shooting of this magnitude, it really ignites fear. Fear in the families, fear in the students, fear in the individual, in the children, in the staff. And in the community, you see a mass panic, a loss of cohesion, anxiety, avoidance of the place where the mass shooting happened. And students may become very irritable with one another. They may turn to drug and alcohol and substance abuse to try to avoid any memories of the trauma. They might experience psychosomatic effects such as headaches or stomach pains, and they're going to fear returning to school or to the location where this trauma occurred. According to the article of Cimolai 2021, there's direct and indirect impact. Direct exposure is when someone witnesses or survives the assault or the attack. And indirect exposure is hearing or seeing images of the event, such as in social media, on the news, on CNN. When a mass shooting or a mass trauma happens in society, it's something that we continuously see in the media and in social media, and it could be triggering and re-triggering every single time. So this is how it doesn't only directly impact the victims and the survivors. They're going to have the most symptoms and the most traumatic effects from this. But when we think of indirect impacts, it can really affect people worldwide when you're constantly seeing these negative images and these violent crimes happening. It does affect society as a whole. This is something that we refer to in psychology as vicarious trauma. This is something that, as a mental health therapist, I worked as a mental health therapist for 6 years. And vicarious trauma is something that mental health providers and first responders, like police officers or ER workers, medical workers, experience every single day. It's a vicarious trauma where the direct trauma didn't happen to you, but because you're responding to the trauma, it traumatizes you indirectly. And with vicarious trauma, it's really important that mental health providers, medical health providers, first responders like firefighters and police, the police force, really are educated and are aware of vicarious trauma, that they have self-care options, mental health days available to them, or anything that they need in order for them to feel a lack of burnout, because with a first responder type of job, there can be a really high rate of burnout from continuous vicarious trauma. So self-care and sometimes your own personal therapy is the best way to handle indirect trauma. Chronic post-traumatic stress symptoms are usually seen more so in the direct victims. It's something chronic that happens because they were exposed to it. This is considered a long-term impact. Both direct and indirectly, people can suffer from depression and anxiety. Short-term impacts can be acute stress reactions, so reactions in the moment, like the hypervigilance or being startled or fear to leave the home. And the long-term impact, you see a persistent post-traumatic stress disorder, and this can really increase a burden in your future and in your functional impairment in society, with your workforce, economics, and in your occupation. And what I mean by this is when I worked as a mental health therapist, we really diagnose people with a disorder. And in this situation, it'd be post-traumatic stress disorder, acute stress disorder. In a situation like this, major depressive disorder, we really need to meet certain criteria. But the main reason that somebody is diagnosed with a disorder is because there is functional impairment in their day-to-day life. And what I mean is, if you're a student who is involved in a mass shooting and you're a survivor, it's going to be really hard to concentrate on your schoolwork. You're going to be living with anxiety. You're going to be living with fear. You're going to be living with depression. And your academic scores may go down. You might socialize less, and so it's going to impact your social atmosphere. And then also, it might impact, if you don't get the treatment you need early on for PTSD, it's really going to impact your occupational future, because you're going to continue with this fear or lack of motivation or difficulty concentrating if there isn't something implemented in the school in order to help the children and to debrief and to make them feel safe again. And we're going to talk a little bit about the treatment and what we can do in a situation like this in the next slides. In learning about mass shootings and the effects of trauma, we really need to understand the statistics. This is part of the psychoeducation piece in mental health or in psychology, is you want to be aware of the statistics so that the survivor doesn't feel like they're the only one. A lot of times they feel like they're the only ones who are feeling the pain and the emotions and the fear when it's really the whole community, society, the entire school is feeling this way. The statistics here are in 2017, 39,773 deaths were due to firearm injuries in the United States. 60% were because of suicide and 36% were because of homicide. There has been an increase in the age of adjusted death rates. There has been an increase in suicides in ages 15 to 24. White males are the highest risk for gun-related suicides. Black males are the highest risk for homicide in 15 to 24-year-olds. And from the years 2000 to 2020, 240,000 children have experienced gun violence. Now, I want everybody to really stop and think about these statistics for a reason. 240,000 children have experienced gun violence in just the recent years. What happens when these children are left to fend for themselves? There isn't a support system in place for them. They don't have the mental health therapist or the medical treatment that they needed during this time. We're going to see those long-term effects in these children. They're going to suffer dearly in their functional impairment, in their social impairment, in their academics, and then they're going to carry this functional impairment with them throughout their life as they grow. And then what are we having? We're having a society of functionally impaired adults who survived these terrible, violent, traumatic events, but they never processed the trauma. And that's why it is so important to have effective treatment in place for traumatic events of this magnitude, because we don't want to forget to help one child. If one child goes unattended, that child can in turn grow up having conduct disorder and oppositional defiance disorder and really reenact and replay this. And then they're at risk, a greater risk for committing suicide because they don't know how to cope with these feelings, especially when they are young adolescents and young children. Their frontal lobe isn't fully developed until the age of 25, and you're asking a very small child to have to deal with emotions that they aren't even aware of, with emotions that they don't even know how to process, and you're adding this layer of traumatic violence that leaves them stunted. It leaves them developmentally and emotionally stunted, and we're going to continue to talk about this. PTSD is defined in the DSM-5 as exposure to actual or threatened death, serious injury, or sexual violence. This is in page 21 of the DSM-5. PTSD could be a direct, or trauma can be from direct experience. It could be witnessing in person, learning that the event occurred to a close relative or friend, and a repeated exposure to an event, such as police officers, first responders, and exposures to details of abuse. Some of these, in the DSM-5, when you're a mental health provider, you really need to follow the criteria in order to be able to diagnose somebody with post-traumatic stress disorder, and also to really be able to see what those symptoms look like in their behaviors, not necessarily them reporting it, because a lot of people don't know how to self-report what they're going through, but you'll be able to see it in those therapeutic sessions with them. They experience intrusive or recurrent memories of the traumatic event, distressing dreams and nightmares, dissociative reactions such as flashbacks, intense psychological distress when triggered, psychosomatic physical reactions to things that resemble the traumatic event, avoidance of thoughts, feelings, or memories, avoidance of external reminders, places, people, and conversations, amnesia, not able to remember certain parts of the traumatic event, living with fear, anger, shame, or horror, negative beliefs about the self, lack of interest, and detachment to others or from others. Post-traumatic stress disorder, you can also see anger, outburst, or irritable mood, difficulty sleeping, hypervigilance, reckless behavior, exaggerated responses, difficulty concentrating. And in children ages 2 to 9, there's an increase of PTSD from one incident. So children usually have a harder time dealing with emotions, and you'll be able to see a lot more externalized behaviors like aggression and prolonged crying, fear, tantrums, temper tantrums from a child within the ages of 2 to 9. In the older youth, you'll need multiple exposures to experience PTSD. It could be. It really just depends on the magnitude of the actual event. So, for example, with a mass shooting like this, if you are a survivor and saw your friend being shot and killed in front of you, you're going to have PTSD. Now, when it talks about multiple exposures, it's the older we get, there we do build some sort of resiliency, right, with life experiences. But in the clinical field, when you have repeated trauma, we call this complex trauma. And that's where we can really see the chronic PTSD symptoms that are carried throughout life. Adolescents who experience trauma can experience internalizing and externalizing problems that can lead to an increase in diagnosing conduct disorder and oppositional defiant disorder. Adolescents may experience emotional dysregulation, emotional numbing, lack of effective empathy, hyperarousal, antisocial behaviors, and aggression due to perceived threat. Post-traumatic stress in children looks a little bit more like prolonged crying, low frustration tolerance. This is what I call the end of the world. I call it the end of the world situation where, something very small and insignificant to us feels like the end of the world to the children because they have a low frustration tolerance and they're going to cry and they're going to have meltdowns and they're going to have tantrums. They might complain of stomach aches, have irregular bowel movements, which you see with a lot of anxiety. Headaches also with stress, depression, anxiety, increase in anxiety, new fears. They might develop new fears to things they weren't afraid of before. Intense feelings of sadness, lack of interest in things that they used to do. So, for example, they used to love going swimming, or they used to love watching a certain show or going bike riding, and now they don't want to. You're going to start seeing this lack of interest. And regressive behaviors. Regressive behaviors in children looks like thumb sucking, sleeping in their parents' bed when they were already sleeping independently in their own bed, loss of developmental milestones that they used to be able to do before. So, for example, I knew a little girl who was 3 years old and she was potty trained. And when her grandfather passed away, it was so traumatic that she went back to temporarily using a diaper because she wasn't potty training anymore. She sort of stunted and regressed to a younger state. In children with PTSD, you see the reenacting and repetitive play of the traumatic event and less fantasy play. So, play is very healthy for children to process emotions. A lot of people don't know this, but when you're a therapist in clinical work who is working with children with trauma, sometimes they develop selective mutism. They are so stunned by the trauma that they don't speak about it. They can draw about it, they might write about it, and they'll play. They'll show you exactly what happened, what they witnessed, and what they experienced through their play. And that's where play therapy and art therapy are extremely important. And we'll talk about that as a treatment in later slides. Some great coping strategies are in order to decrease these externalizing behaviors that we see in children or adolescents who experience trauma after a mass shooting is parental involvement. You really want the parents to be their main support. Professional support, as in mental health therapists, guidance counselors, family members, friends, church groups can be considered professional support, emotional recovery. using evidence-based practices just such as post-traumatic trauma-focused cognitive behavioral therapy. That's considered an evidence-based practice, and I'll speak about it a little bit more. I am certified in trauma-focused cognitive behavioral therapy. I worked with the TFCBT model for 2 years in children and adolescents, and I really am a true advocate and believer that it works and that it's effective. And you also want to build a high support system from their family, because they're the ones that they live with. They're the ones that are going to see if they're having difficulty coping, if they're having symptoms. When I was a mental health therapist, I always told the parent, you're the expert of your child. You're the one that's with them 24/7. You're the one that's going to see if they're throwing tantrums, and if they're crying, and if they're refusing to eat, and if they're refusing to sleep, and they're refusing to speak. You're the one that's going to be able to tell me what's happening in your child's life. So I think it's important when you're a mental health provider to really assist the parent in understanding what the child's going through, but really giving them the reins of, I need you to report what's happening with your child in order for me to understand how to help them, and developing that relationship with the family. The number one thing that is almost taken from a victim of mass shooting or a victim of trauma is safety. Their safety is completely stripped away from them. They don't feel safe anywhere. They don't feel safe at home. They don't feel safe in the community. They don't feel safe at school. They might not feel safe with people they used to feel safe with. And the number one thing we need to focus on is making them feel safe again. So safe place interventions really need to be implemented in the schools and by mental health providers and in the community. So developing a safety plan. When I worked with adolescents, I developed a safety plan. So if they had suicidal thoughts, if they had things that were so triggering for them that they felt out of control that they couldn't control it, who were their safety people, and also a list of their safety skills, making a survival toolkit for them. Do you have a happy song? Do you have a place that makes you feel calm and safe, like going to the beach? Do you have a friend that you can just, or a parent who hugs you and makes you feel safe? You really want to be able to create a safety plan for them, especially to decrease the suicide rate of the survivors who are living with survivor guilt. You want to make sure that there's a safety plan so they do not commit suicide. Educating school administrators, primary care physicians, policymakers, threat assessment teams, and to implement a standard procedure response to school shootings, and having those drills that they have now at the high schools, lockdown drills, because the truth of the matter is society is changing, and unfortunately we do have what I call a traumatized society. We have a traumatized society of people just walking around with post-traumatic stress disorder, and our current pandemic didn't really help that situation whatsoever. It just instilled even more fear. And so I think it's so important for first responders like law enforcement and mental health providers and government officials and teachers and educators to just come to a table together and see how we can implement better policies for these type of traumatic events that are happening, because they aren't being dealt with. There are so many people who need support and help, and they aren't getting the help that they need, especially when it comes to mental health and trauma. And sometimes mental health services are the first thing that gets cut, right? We can't afford this, so mental health services get cut, and it's such an important resource to many people for their overall well-being and their health. So let's talk about treatment, right? We've talked about the effects of trauma, who it impacts, what it looks like for survivors of mass shootings, the risk of homicides and suicide afterward. But a lot of great treatments are out there and are available, and sometimes we need to just be able to provide those resources or to look for them. Trauma-focused cognitive behavior therapy, art therapy, group cognitive behavior therapy. Group therapy and support groups are great for school shootings or a violent event that happened in a community. Support groups, play therapy, especially for young children who have developed selective mutism due to trauma, and art therapy, they can really express themselves through either play or art. Eye movement desensitization and reprocessing, we call this EMDR, which is really a tapping process of how the traumatic event and memory is stored in our brains. Prolonged exposure, there has to be some sort of desensitization and prolonged exposure to the place where it happened so that the person can feel safe there again. So for example, in a school shooting, you have these children walking down the halls where their best friend was killed, or where their teacher was killed, or where the student who used to sit behind them in English is no longer alive. And they go back to English class, they sit there, and that student's no longer there. It's going to be so triggering and so traumatizing again, and they're going to live with this anxiety and sadness every time they sit in that seat. And we're going to have to help desensitize them so that when they go back into English class, it doesn't feel scary anymore. We're going to have to make that and create that into a safe place for them, and it's going to take time, and it's going to take prolonged exposure. Psychotropic medication for chronic symptoms can also be necessary. It really depends. Therapeutic services should always be your first route before before seeing a psychiatrist, before receiving any type of psychotropic medication. The reason being is you want to make sure that medication is needed in very chronic symptoms that aren't being alleviated by any of the coping strategies that you've taught them, any of the treatment that's been implemented. The difficulty with medication is that certain medications, so for example, a tricyclic antidepressant medication, it doesn't trigger just one receptor in the brain. It triggers so many. So there's so many side effects to it, right? Like dry mouth and decrease in libido. And what ends up happening is if that person really does not need the medication, it could cause an imbalance in their neurotransmitters and in their brain and cause them to commit suicide. So it's really difficult when it comes to psychotropic medications that these providers aren't just administering this medication on one visit, that they consult with medical professionals. Psychiatrists need to consult with therapists who see them all the time and parents who see them all the time to see what's working and isn't working, and that they're being monitored closely if they are taking any type of psychotropic medication, because taking medications can really alter somebody's personality based on what is happening with the receptors in their brain. So I'm really pro therapeutic services prior to psychiatric services, although I do understand in working with psychiatrists in the past that medication can work for people who really need it, who have low serotonin levels or low dopamine levels. I mean, this is something that needs to be tested. If it's something that's a chemical imbalance, it could really be helpful, or it can be a temporary assistance while people are really dealing with chronic symptoms. But we really want to try to avoid medications at all costs. I'm going to talk to you a little bit about the trauma-focused cognitive behavioral therapy process. I am certified in TFCBT, and I worked as a mental health therapist with this model, like I had said before. So there is psychoeducation, really giving them those statistics that I talked about earlier, and what it looks like when somebody survives a school shooting, so that they know that it's something that has happened before and that they're not the only ones that are going through this. It helps them to understand, well, what's happened and why is this happening to me? And it helps them ask those questions of that sometimes we might not be able to answer. Because unfortunately, with a mass shooting, we don't always know the motive behind why that person chose to shoot. Sometimes it's a murder-suicide type of situation and they weren't able to interview the perpetrator. And there's a lot of unknowns. And it really, psychoeducation really gives the client that safe space to ask those questions of why, and being able to process that and trying to make peace with some of those unanswered questions. Parenting skills, we want to talk whatever we show the child in TFCBT, you show the parent. So you teach the parent psychoeducation, you teach them the relaxation skills, identifying emotions, affect regulation, your safe place, your support system. You teach the parent all the coping skills that you're teaching the child so that they can help guide them at home when you're not there. So if they see that the child's hyperventilating or looks like they're afraid, you could say, hey, what did your therapist teach you? Remember we talked about that relaxation skills? Let's do some belly breathing. Or how do you feel on a scale from 1 to 10, your anxiety? You're feeling at an 8? Okay, what makes you feel better? Drawing? All right, let's go do some finger painting. And really helping the parents take a lot of that lead in supporting their children at home. You want to make sure they're able to identify emotions and to regulate those emotions. You want to make sure there's affect regulation and identification. So affect is if our facial cues are matching what we feel. So if I say I'm feeling really happy right now, yeah, that's so great, but my face is not reflecting that, I'm not smiling, my tone is very monotone. I might say, well, you're saying you're happy, but your face isn't matching that. And really able to help them match the emotion to their facial expression so that you can say, look, this is what it looks like. Hi, I'm happy. I'm smiling on my face. My tone is kind of high pitch as opposed to very monotone. I'm very happy. Yeah, that's great. You can really tell the difference. Those modulation skills really come with helping with affect regulation and identification, and you'll be able to see the difference in treatment. You have the in vivo desensitization, like I explained about prolonged exposure, having to desensitize them to their school, to a regular, beautiful environment that they used to love to go to, and now it's scary. So it's really having the in vivo desensitization that they might have to implement, maybe a few hours there, close off that certain section. Okay, maybe they can come back a little bit closer to that area, a little bit closer to that area, and slowly expose them back to that situation or to that place so they can feel safe again. Personal safety, what are you going to do to keep yourself safe? What would you do in a situation like this in the future? Assertive communication versus aggressive communication. A lot of post-traumatic stress victims, a lot of trauma victims really become aggressive. And it's not because they are aggressive people by nature. It's because they've endured some sort of violent act that causes them to be on self-defense mode all the time and hypervigilance mode all the time, where little sounds are startling them. So for example, if they saw the shooter behind them, they're really going to have a hard time with people behind them, right? They're going to feel uncomfortable. They might have certain abrasive movements that goes like this when they hear a certain sound. Watching certain movies that have gun violence in it might really make them scared, run, break down, hide. So we really want to make sure that we help them learn how to communicate what's happening to them and understand what's happening to them, because that aggression it's almost innate. It's this natural instinct of survival of, they're going to hurt me, let me save myself, let me run, let me hide, let me attack first. It's a natural instinct that happens, and we have to try to bring down, the nervous system a little bit and help them see that they're safe. If they don't feel safe, they're going to react with instinct that way. And so you want to make sure to change their aggression to assertive communication of, can you please not stand behind me? That makes me feel uncomfortable. Or can you please not run towards me that way? The last time someone ran to me like that, they hurt me, they attacked me, and it startles me. So can you just approach me by walking instead of running? And being able to assert yourself of, this is triggering me. Can you give me space? Can you help me here? There's the conjoint sessions, family sessions, the child and the parent. So the child and the adolescents can tell the parent how they feel about the situation and what they're going through, and the parent can also respond to how they feel about the situation, and bringing that family unit together to be a support for each other. And then the narrative piece. I'm going to speak in detail about the narrative piece in the next slide. The narrative is sort of your last but most important piece when it comes to TFCBT work. And I'm going to explain it to you like this. When we ask someone to share their trauma story, it's like we're cutting their arm again. It's like you have a cut in your wound and it's bleeding, and then you put a band-aid over it. And then somebody asks you to talk about it, and then you rip that band-aid off and it starts bleeding again. And then you put a band-aid back on it. And then someone asks you to talk about it again, and then we rip it off and it continues. This is unfortunately what happens with responders, right? They're interviewed by social media, by news reporters, they're interviewed by their therapist, they're interviewed by a social worker, they're interviewed by a police officer, they're interviewed by teachers, by their parents, what happened. And so by the time they're done talking about it, they've had to talk about it 8 different times without anybody helping them process the emotions, without anyone helping them make sense of what happened, without anybody guiding them through this. So we're just re-traumatizing them over and over and over again. And so there has to be a way to help them. And this is what the narrative does. It's after you've taught them the coping skills and helped them to identify their triggers and to assert themselves, you can really help them with the narrative piece. And so with a narrative, it's really important to know when to move on to the narrative and when to stop the narrative and take a break and help them with those relaxation techniques or those coping skills. So when I did the narrative with one of my clients, I made sure to say, how do you feel on a scale from 1 to 10, when I could see that something that she was talking about was clearly triggering her. And she said, I'm at an 8. We're going to stop. What do you want to do? Let's look at your safety kit. What are we going to do? I want to put some music on and listen to my favorite song. Okay. Then we listen to her favorite song together. Then after the song's over, how do you feel on a scale from 1 to 10 and your anxiety level? I'm at a 2. I feel okay. All right. Do you want to end session for today? We don't have to continue since you feel calm and at peace right now, or we can continue. And at times she would choose, no, I think I'm done for today, or I'm okay. Let's continue. And we would continue the story. And if she was triggered at an 8 again, or anywhere between 7 and 10 or highly significant, we would pause and we would use one of our relaxation or coping skills so that she could get through it without hurting her, without rewounding her, without re-traumatizing her. And it was very, very successful treatment for this 13-year-old girl that I worked with. When it comes to the narrative, 1, you cannot write the narrative until you're able to identify triggers and to express your emotions. 2, you cannot write the narrative until you understand and apply your coping skill strategies, like I explained in that example. 3, the narrative is guided and it can be as short or long as you want it to be. It's their story. 3, the narrative must include the worst moment of the trauma because we want to make sure to address it. We want to make sure to process that in their narrative. The narrative must include a future for closure. So when you do the narrative, it could be different chapters, right? With this specific 13-year-old adolescent that I worked with, she had about 5 chapters. We made sure one of them was the worst moment, but the last chapter was her future. And the future includes what she wanted to do when she grew up. She wanted to be a mentor for other children. She wanted to grow up to be a mentor, to teach other kids about what she had learned. She wanted to, graduate high school and be successful. She wanted to be in anti-drug campaigns. She wanted to develop a great relationship with her sister and her family, and it really brought her so much closer to her parents, and she felt really supported by them. And all of this went in her future chapter of what she wanted to do when she grew up and what were her interests and made her happy and what was her safe place so that she could have it with her and always go back and read it and look to it. Now, the rest of the trauma story, they don't get to keep. They can rip it up into shreds if they want to. The therapist can hold on to it, whatever they want. But it's almost like you're putting this closure to the past and saying, I don't need this anymore because I have my future and I have my coping skills and I have my relaxation techniques and I know what I want to do when I grow up and I feel motivated and I feel positive again and I feel mentally well again. And that's what we want. You want to leave them with their future, with something positive that they can carry with them and they can look back to. And I told them, if you never want to talk about this ever again, you don't have to. You never have to talk about it again if you don't want to. But she wanted to be anti-drug, campaign advocate, and she was able to talk about it. She was able to talk about it and talk to other kids about it in her high school without feeling triggered or traumatized because she had made peace with it. And I'm so proud of her. She knows who she is in the world. I am so proud of her. And the narrative can be written in chapters. It can be drawn in pictures. I had a younger client who was 7. She didn't know how to, write a whole book about it. So she drew pictures with a little sentence on the bottom, and we made a picture book out of it. And she was able to share it with her family and really have that closure as well. And it really depends on the age group of what process we're going to take with their story. These are my references here if you would like some further information or to read more on the effects of trauma on mass shootings or school shootings. If you have questions, please feel free to reach out to myself or to my instructor. Again, my name is Esmeralda Teresa Hernandez Polanco. You can reach out to me at ethpolanco@gmail.com, and I can always provide you with resources if you feel like you are someone who needs trauma treatment and you are someone who needs a mental health referral. I can always refer you to a wellness center or somebody in the community because I don't want you to feel alone. I want you to feel that there's support out there and that there is somebody who cares and who listens and who will give you the right referral and point you in the right direction so that you can feel safe. Thank you very much and have a great day.